Oh, so much excitement. So, my last duty tonight is I have the distinct honor and privilege of introducing tonight's Talairach speaker. The Talairach Lecture is intended to expand the frontiers of the OHBM's community's vision for our current and future work, to excite, challenge, and inspire all of you who are just starting out in your careers and to those who have been hard at it for decades. In that spirit, it is my great honor to introduce this year's Talairach speaker, Dr. Lozano. Dr. Lozano is the chairman of the Department of Neurosurgery at the University of Toronto and holds with it the Dan Family Chair in Neurosurgery. Our time is short, so I promised I'd cut my talk short so I could give him more minutes. So I'll just say, Dr. Lozano is best known for his electrical recording and stimulation mapping of previously unexamined brain areas and for the identification and testing of novel therapeutic targets for deep brain stimulation. He is an accomplished speaker, educator, and mentor, and I am wise enough to quickly turn over this microphone to him. Dr. Lozano, thank you for being with us today.
Well, thank you so much, Professor Golub, and it's such a pleasure to be here in Glasgow with you and to deliver the Talairach Lecture. I'm going to be speaking about imaging of the brain to discover new therapeutic targets as it applies to functional neurosurgery. These are some disclosures, and I'm particularly honored to give the Talairach Lecture. Talairach was a psychiatrist and a neurosurgeon. He worked at St. Anne. He started off life as a violinist, became a psychiatrist and neurosurgeon, and went on to map out the catacombs of France for the French resistance during World War II. He developed a system of coordinates for the brain. He was an epilepsy surgeon, a brain cartographer, and we have the Talairach Atlas and coordinates. So it's really humbling to follow in his footsteps and to give the Talairach Lecture. What I'd like to do today is talk about three topics. One is the possibility of using deep brain stimulation to treat Alzheimer's disease. Two, to discuss fMRI brain activation with deep brain stimulation to guide programming of stimulation. And three, magnetic resonance guided focus ultrasound. And for those of you who are not familiar with this, the focus ultrasound involves shooting 1,000 beams of sound through the skull to brain targets anywhere in the brain. And deep brain stimulation involves placing electrodes anywhere in the brain and hooking them up to a pulse generator to be able to modulate the activity of dysfunctional circuits in neurologic and psychiatric disorders. Just to give you an idea, brain stimulation with DBS is being used in over 40 disorders, and there are over 50 targets in the brain that are being examined. And so really no neuron is safe from a neurosurgeon. We can go anywhere in the brain and place these electrodes to modulate the activity of dysfunctional brain circuits. One of the things I'm going to be talking about is on the list near the bottom, you'll see that obesity and Alzheimer's are part of the potential disorders that are being targeted with DBS. And I'm going to be talking about those now. So the story starts with obesity and being asked as a neurosurgeon to treat a patient with morbid obesity who had failed all kinds of treatments. So we looked into this, I looked into the literature, and indeed there's something known about the control of appetite in animals, and we know that the ventromedial nucleus of the hypothalamus is involved in satiety. And if you destroy that nucleus, then you are no longer satisfied, and you end up looking like that beast on the left. On the other hand, there's also ventrolateral nuclei in the hypothalamus, and those are responsible for hunger. And if you destroy those, then you are no longer hungry, and you become emaciated like the animal on the right. So we weren't interested in lesioning these nuclei in a human, but we were interested in stimulating them. And so we got permission from our IRB to implant one patient with morbid obesity. And this was a man who was 53, who weighed about 190 kilograms, had a BMI of 55. And these operations are done with the patient's awake. And we're implanting electrodes in the hypothalamus in these areas of the brain that control appetite in the animals. And we are looking for a spot where when we stimulate, the appetite goes down, the hunger goes down. So we ask him, how hungry are you on a scale of 0 to 10? 10 being the maximum, and his answer is 9.5. That's his baseline, 9.5 out of 10. And we're putting an electrode in his hypothalamus, and we're stimulating, looking for a spot where his appetite and hunger goes from 9.5 to something less than that. So he's awake, and we're stimulating, and we proceed with this. And the first spot we're in, the top of the hypothalamus, we stimulate, and to our surprise, he gets this vivid déjà vu experience. He says, I'm 20 years old, and I'm in a field. And, what are you doing? It's not quite sure. We turn it off, the sensation goes away. We turn the current up higher, and this experience gets more vivid. I'm in a field, I'm with my girlfriend. Turned up even higher, he hears the sounds, he sees the birds, the smells. So a very rich experience appears as we increase the current in the brain. So we become very interested in this memory phenomenon, and we didn't want him, we didn't leave it at this high voltage. I have to emphasize that these vivid memories only occur at very high currents. So we didn't want him to think that he was 20 years old and had a beautiful girlfriend. We thought that was inappropriate. So we wanted instead, we sent him home at 3.5 volts, which is a low current. And then we tested him psychologically at baseline and after a month of chronic stimulation at this low current. And to our surprise, his verbal memory shot through the roof. He had a huge increase in his verbal memory with this chronic low level of stimulation in his hypothalamus and in his fornix. And he, in fact, increased his verbal memory on the California Verbal Learning Test from about a 40 or 50th percentile to a 70 or 80 percentile. So this represents a very large rise in his verbal memory skill. So we published this paper called Memory Enhancement Induced by Hypothalamic Fornix Deep Brain Stimulation. The implications of this work is that indeed the neuroanatomic circuits mediating human memory are accessible, and the function of these memory circuits can be modulated with electrical stimulation, and maybe there might be a therapeutic opportunity. So what we'd like to do is to take this observation and then see, could it be used for something else? And our idea was, could we use this observation and stimulate these circuits in patients with memory disorders? And we chose to stimulate this circuit in patients with Alzheimer's disease. So we conducted a phase 1 trial in 6 patients, 6 subjects with mild Alzheimer's disease. And the idea here is, of course, that you have pathological changes in the brain with Alzheimer's disease, like neurofibrillary tangles and senile plaques. This causes the neurons to malfunction. The synapses are dysfunctional. That, in turn, leads to circuit malfunction and network disruption. And this is what we believe leads to the signs and symptoms that we know are characteristic of Alzheimer's disease. We also know that the brain shuts down and stops using fuel. On the bottom, you see a PET of a fluorodeoxyglucose glucose scans, and as you progress from normal to Alzheimer's disease, there's a fallout. The brain stops burning fuel, particularly in the temporal and parietal lobes. And so this is direct evidence of the network dysfunction that we see in Alzheimer's. Brain areas just simply shut down. They no longer use fuel. So our approach was to place the electrodes in exactly the same place that we placed them in our patient with obesity. This is a sagittal section through the brain, and the structure that we're targeting is the fornix. Do I have a pointer, by the way? Is there a pointer somewhere? So the fornix is this columnar structure in the brain. And what we're going to do is we're going to place an electrode to stimulate the axons of the fornix. The fornix contains 1.2 million axons in humans. They are myelinated. They are 4 to 6 microns in diameter. And what we want to do is place an electrode not in the fornix, not in the axons, but rather right in front of the fornix, which is parallel to the DBS electrode you see there. So here is the fornix, and here are the axons. And what the idea here is to stimulate the circuit of Papez. And here is the first human being in the world where we have an electrode just in front of the fornix with the idea of stimulating the fornix. And this is a patient with Alzheimer's disease. The first thing we wanted to do is what happens in the brain when we stimulate the fornix, and we did something called S-Loretta. So we're stimulating through the electrodes, and we're mapping using low-resolution EEG tomography, Loretta. We're mapping what areas of the brain become activated. We're looking at the power of the EEG. And what we see is when we stimulate through the electrodes, we get activation of the hippocampus and the entorhinal cortex. And if we wait a bit longer, we see that we get, in fact, transsynaptic activation of the entire circuit. So we see the cingulate gyrus here, and we see the entorhinal cortex being activated. So by stimulating focally at the level of the fornix, we are having not just a direct effect on the fornix, but we're also having an effect on the entire circuit. We're able to get transsynaptic activation of the entire circuit. Now, we're in Scotland, and I'm going to show you a patient that we do this in the operating room. The patients are awake, and she was from Scotland, so this is, I think, rather appropriate. I'll ask you to click on the video so we can play it, please, and play the sound.
Once again, Lozano.
This is a patient with Alzheimer's disease. She's 65. We're in the operating room.
Turn this machine on. You tell us if you feel anything, okay?
Okay.
5.
So we're at 5 volts.
It looks like there's a group of people.
Right. There's some people?
I believe that they're people, but I can't say for
So she
sure.
gets a vague memory.
Well, it's hard to tell.
Hard to tell.
Yeah.
Is this like a new scene, or is it a scene from your past?
I would, oh, jeepers.
Is it something you've seen before, or is it something brand new?
Maybe.
With a few
We increase the voltage.
Remarkably, the details of the image get sharper.
We lived in this palatial place in Scotland where
From deep within Moira's brain, a childhood memory surfaces.
we just had all kinds of parkland to run around in.
So
and everything.
that just came into your
Yeah,
mind
when
now?
I saw that, because the way that the picture is,
Right.
it's grouped,
Okay.
and I'm pretty sure it's a grouping of my sister and my brother.
This vivid memory flash is a sign that Lozano has hit the spot.
I think it's very suggestive that we're in the right place, that we're in a circuit in the brain that regulates memory and that we're able to tap into it. We hope that this then translates into being able to activate this circuit and to boost up its function, and this in turn will lead to an improvement in memory and cognitive function.
So I'm thrilled that she was from Scotland and that she recalled a memory from Scotland, because we're in Scotland, of course. So this lady was 65, and I asked her, when's the last time you thought about that grouping of your brothers and sisters? And she said, I hadn't thought about that since I was 8 years old. So somehow that memory was in her brain, and by stimulating her fornix, we were able to unlock that particular memory. Now, the goal of the surgery is not to get to people to recall their childhood memories. The goal of the surgery is to help Alzheimer's disease. One of the things I told you about earlier is that there's a glucose utilization deficit in Alzheimer's. And the first 6 patients that we treated, we in fact described that in the figure on the top, where you see these areas in blue are areas where there's less glucose metabolism compared to age-matched control. So the lights are out in these areas of the brain. And the question is there someone home? Can you turn the lights back on, or are they out irrecoverably? And so we turned on the stimulators, and we were able to see that indeed these areas in red are areas where there's an increase in glucose utilization in the brain. So it looks like indeed the lights were out, but it is possible to increase glucose and to get these areas of the brain to use glucose once again. And we think that's very exciting, because if we get these areas of the brain to come back online and use glucose once again, it means that perhaps their functions will also return. So we're quite excited about that observation. One of the other aspects of Alzheimer's disease is that there's progressive atrophy of the brain in the entorhinal cortex and in the hippocampus. And as you progress from mild to moderate to severe Alzheimer's disease, you get a shrinkage away of the entorhinal cortex, and the hippocampus just about disappears. And as you progress along this spectrum, your memory gets worse and worse. So here, for example, you forget people's names. When you're at this stage, you probably don't recognize your children, right? So as you lose these areas of the brain, there's a progressive worsening of your cognitive function. And the question is, what happens if a neurosurgeon stimulates this circuit 24 hours a day? What happens to this process of atrophy? Does it make it better? Does it make it worse? Or is it draw? So what we did was we looked at what is the rate of atrophy, and in these 11 studies, the average rate of hippocampal volume atrophy is in the order of 5% per year. So the question is, when you stimulate, what happens to the hippocampal atrophy? Does it stay at 5% or does it change? What we did was we measured the volume of the hippocampus, and 2 postdocs did this work. We used a manual segmentation, and we painted the hippocampus across the MRIs, and we then measured the hippocampus in our first 6 patients. And the patients are numbered 1 to 6, and there's a red and a green postdoc, Monica and Antonio. And basically what you see is that patients 2, 3, 5, and 6, they lost hippocampal volume anywhere between 3 and 14%. But we got a surprise, a huge surprise. Patients number 1 and number 4, they did not lose hippocampal volume. In fact, their hippocampus got bigger. And at first I didn't believe this. I made them recheck, and indeed it looks like this was reproducible. There was a very high correlation between the two patients. So this is the first example that deep brain stimulation not only changes the activity of the brain, deep brain stimulation also changes the structure of the brain. We wanted to understand what was the basis of this phenomenon. So with Talairach Chakraborty, we stimulated these circuits in rodents, and sure enough, not only can you get a human hippocampus to grow, but if you stimulate a rodent in this circuit, you can also get the rodent's hippocampus to grow. And it can grow by 15 or 20%, as shown here. So this is quite reassuring that by stimulating the circuit, we can get the brain to regrow. And the question is, what's going on here? And, is this a dangerous thing? I mean, we don't want the brain to keep on growing and growing the hippocampus. I mean, at some point, your head might explode if it keeps on growing, so we don't want that, certainly. So what is the mechanism, and what is contributing to that growth? And so with Dr. Chakraborty, with Talairach, he did staining for blood vessels, for astrocytes and synapses, and there were more synapses in the rats that had DBS, and there was also more blood vessels. And indeed, if you do a collagen stain, you'll see that there was a great increase in the volume of blood vessels, and we think that this alone accounts for the change in the volume of the hippocampus. There are more blood vessels being formed, and this is sufficient to explain the increase in the size of the hippocampus that we see in the rodents. We then moved on to a phase 2 study with 42 patients with Alzheimer's disease, and what we found in this study is that in patients over 65, DBS appeared to slow down the rate of deterioration in these patients with Alzheimer's disease. And we wanted to know what were the neuroanatomical substrates responsible for this phenomenon, and so we mapped out the electrical fields that were associated with improvement. We mapped out the fiber tracts that were stimulated using a brain connectome, and we also mapped out the networks that were influenced by these targets using brain connectome. And this is work done in collaboration with Andreas Horn from Mass General. And what we discovered is here are the electrodes, and here's the fornix, and we found that the best electrode was this one here at the top, the one that was stimulating the fornix and also at the level of the anterior commissure and the bed nucleus of the cerebrospinal terminalis. So this is the hot spot, and if you go at the lower electrodes, you do not see these improvements. You also see this memory phenomenon, these memory déjà vu flashes, only at the top contact, and you do not see them at the bottom contact. So it appears that the fornix at the level of the anterior commissure is the best target. This in turn involves the circuits, the fiber tracts of the fornix, the mammillary bodies, and the mammillothalamic tracts. These are the tracts that you stimulate that seem to be associated with the best clinical benefit. And this in turn involves these networks in the cingulate gyrus, in the prefrontal gyrus, and in the temporal lobe. So this appears to be the neuroanatomical substrates for these benefits that we are seeing in the patients with Alzheimer's disease. Where we are now is in a pivotal trial, a phase 3 randomized trial. We are going to operate on 200 patients with mild Alzheimer's disease. These patients are all taking acetylcholinesterase inhibitors. They have a minimum age of 65 because we found that those over 65 surprisingly do better than those who are younger and have a more malignant form of Alzheimer's disease. We measure their CSF A, beta, and tau. It is a double-blind sham-controlled patients where all the patients get implanted and then they're assigned to 3 different arms. Either they're assigned to on at 130 hertz, at a high frequency, on at 40 hertz, or they are off. So for a whole year, these patients are off, and after a year, we see whether they can convert to on stimulation. And after a year, we'll see whether this is safe and whether this is effective and whether this could become a new treatment for Alzheimer's disease. I'm now going to move to brain activation with DBS for programming, and we're going to use fMRI for this. So there is an arms race with the number of contacts in these electrodes, and it's taking a very long time to go through all these contacts and to see the clinical effects. Furthermore, the clinical effects are often delayed, and so you turn it on and you have to wait for several weeks or months. And so what we really need is a biomarker that we've achieved the right programming. And we think that fMRI could generate such a biomarker telling us that, you have the right setting, the right contact, the right current. So first we had to show that the fMRI sequences were safe. So we've done this in over 100 patients, and we did phantoms and modeling to show that indeed the fMRI sequences are safe. And this is our protocol where the patients have implanted electrodes, in this case with 4 contacts, and we go contact by contact, we turn each one, and we see which pattern is generated in the brain using fMRI. And indeed, the patterns change completely as you go from one contact to the next. So we do this block design where the IPG is in place, and the simulator is turned on or off for 6 times, and then we see which is the pattern of brain activation that we see. We also know from historical patients which contact is the best one, so we know which is the best contact, we know which is the best pattern, the pattern of fMRI that is associated with the best clinical outcome, and so we use that as the teaching set to generate this data. So this is what we found. When the settings are optimally set, the correct contact is optimally set, we see a deactivation of M1 and of the contralateral cerebellum. As you move away to adjacent contacts, you lose this pattern and you get off-target effects. So this is the signature of a good programming. This is what you want to see on the fMRI. We choose the contact and then we also choose the voltage. We can go up and down with the voltage until we get the maximum signal generated. And in this case, we see in this pattern, we get a lot of deactivation, less so here. And if we go at a very high voltages, you get off target effects with activation of other areas that are not relevant. So this is work done by Boutte in a lab, or postdoc in a lab. So what you see here is our programming paradigm now, where we are doing fMRI, we are identifying the optimal contact, we then get the right contact, and we do another series of screening, and we choose the right voltage, we use a classifier of these machines, and then we are using the fMRI to program the patients. And the question is, what's better, the neurologist programming the patient, trying a setting and seeing how the patient does, or the fMRI? So we're doing a trial comparing the neurologist to fMRI as a way of programming the DBS electrodes. We're also doing this not only in Parkinson's disease with subthalamic nucleus stimulation, but also with subgenital cingulate gyrus stimulation for depression, and also GPI stimulation for dystonia. And this is particularly important because here, when you turn on the stimulator, you don't see anything right away. So you don't have the clinical feedback to tell you that you're stimulating the right contact at the right level. So now we really need a biomarker, and we think we're on the cusp of identifying these biomarkers. And Gavin Elias and Aaron Lowe, who are postdocs in the lab, have generated this data. Lastly, I'm going to tell you about a magnetic resonance guided focused ultrasound as a new technique and its potential in neurologic and psychiatric disorders. So this technique can be used to lesion the brain, it can be used to simulate the brain, and it can also be used to open the blood-brain barrier. So this is what it looks like. The ultrasound, 90% of the ultrasound energy gets blocked by the skull. But if you shoot 1,000 beams of ultrasound, they can all converge onto one point. And just like you can burn a hole in a piece of paper with a magnifying glass by focusing the sun rays, you can burn a place in the brain by focusing the ultrasound onto one spot. So this is done non-invasively. The sound waves come from the outside. We don't have to make any incisions in the skull. The patients go into this machine. Here are the 1,000 transducers with the ultrasound. We're able to aim using MR thermometry, so the MR is exquisite at measuring temperature. We shoot ultrasound for about 13 seconds, and in this case, we heated an area, a volume of 2 by 2 millimeters in the brain to 60 degrees, and that is enough to produce a lesion in the brain, a therapeutic lesion. And it looks something like this. So here you see the lesion immediately afterwards, and we've made an 8 millimeter lesion in the brain using this technique by shooting these sound waves through the skull. So what does this look like? I'll ask you to turn on the video, please. So this is a patient with essential tremor. So this is a man who's in his 60s, who's had tremor since the age of 15. And you can see how disabling. It does not respond to medications. He's trying to drink a glass of water here. He can't do it. And here he's trying to write his name. You see quite disabled he is. Okay, turn on the second video, please. So he goes into the fMRI machine.
After several hours, Tony is brought out for
And he comes out, we treat him, and he comes out, and now he can drink water. So I asked him, when's the last time you could drink a glass of water? He says, it's been more than 10 years since I've been able to drink a glass of water. So this technique is going to revolutionize neurosurgery because it is non-invasive. We do this as an outpatient procedure. We do 4 of these procedures per day, right? And so the patients come in with tremor and they leave the same day and they go home. We published this with a group, a consortium in the New England Journal of Medicine about 6 years ago, and on the basis of these results, the benefits and safety, this is now an approved therapy, and this is done all over the world now in this kind of treatment. We can also envisage that other targets in the brain could be used, not just the thalamus for tremor, but also pallidotomy or subthalamotomy for Parkinson's disease. We can also do psychiatric disorders. For example, we can do bilateral anterior capsulotomy in this non-invasive way. We can make lesions in the anterior limb of the internal capsule, seen here, in patients with OCD or depression. We can also treat patients with deafferentation or central pain by placing electrodes in the centrolateral thalamus as well. So I think that all brain targets are now accessible, and we can make therapeutic lesions in the brain using this technique. Lastly, we can also stimulate and open the blood-brain barrier. So let me tell you a little bit about that. Play the video, please. So we can shoot the ultrasound with a single transducer, and we can stimulate the brain. And this is shown here. This is a video by Jamie Tyler. And this is a mouse, and we're stimulating with ultrasound, and every time the ultrasound is applied, you see that the cortical spinal tract is activated. Next slide. So indeed, we know that there are mechanosensitive receptors in neurons, and there's also gas bubbles and cavitation effects. All of these things can contribute to the activation of axons and neurons and lead to action potentials in the brain. We've started doing this in humans, and we're able to show that we can modify the activity of the motor cortex. We can increase the sensitivity of the motor cortex using focused ultrasound. And one of the interesting properties of ultrasound is that we can reach deep targets in the brain. So in contrast to TMS, transcranial magnetic stimulation, which is mostly the surface of the brain, we can penetrate 8 centimeters into the brain. And so this means that for the first time, we have good access to deep targets in the brain using this technique for stimulation. So that means that we could use it for cerebral mapping, for example, mapping motor sensory speech functions, etc. We could study the effects of DBS at deep targets. So prior to deciding which target to go on, we could stimulate each target with ultrasound and decide amongst several targets which one might be the best suited for that particular patient. And finally, if we applied this chronically, maybe we could actually replace DBS, right? So, and you could do this hopefully without having to do an operation as well. Lastly, I want to talk about opening the blood-brain barrier. And the blood-brain barrier can be opened using ultrasound, and for this, we use microbubbles. So we have to inject microbubbles, which is a contrast agent, and the ultrasound will make the bubbles expand and contract. As they expand, they disrupt the tight junctions that bind the endothelial cells. And when you do this, then you open the blood-brain barrier. So this was the first patient that was treated in Toronto by my colleague Todd Mainprize. This is a patient with a glioblastoma. And we shot the microbubbles, and there were 9 ultrasound sources, and you can see the 9 of them here. And after the blood-brain barrier is open, the way we can tell is that we give gadolinium, and gadolinium escapes. And that tells you that the blood-brain barrier is open. So here's an example where these 9 dots in a sugar cube pattern have been opened by the focused ultrasound. If you wait 24 hours and you give gadolinium again, it does not extravasate anymore. And that indicates that the opening is reversible. The blood-brain barrier reconstitutes itself after 24 hours. And then, so you have this window of opening the blood-brain barrier for a few hours, and during that time, you can get things into the brain that would otherwise not enter the brain. So what are we discussing here? We're talking about getting things like antibodies, gene therapy, for example, or we could do gene correction, we could do antisense oligonucleotides, we could clear pathological proteins. Just to give you an example, this is an animal in which a tomato red gene has been injected directly in the brain. It turns red. This is an animal where the blood-brain barrier has been disrupted and an intravenous injection of the virus has been given. And the virus goes only in the brain where the BBB has been open. So here's an example of doing gene therapy in the brain without having to do an operation on the brain, by giving intravenous drug and it going only in the brain where you've opened the BBB. Of course, if you give it intravenous, it goes not only in the brain, but it goes to every other organ in the body. So this still needs a bit of work. But there are ways now of trying to focus the attention, for example, inject it into the carotid, or trying to engineer genes and viruses so that they are more specific. So this brings us then to our conclusion. And what I want to tell you is that, I had never imagined that we would start off with obesity and see this patient that had these vivid memories, and this serendipitous observation might lead to the concept that, in fact, one can enter the brain, go into memory circuits, one can use electrical stimulation to drive memory circuits, and this may have some benefits for our patients with Alzheimer's disease. It's also quite clear that DBS changes not only the activity of the brain, but DBS changes the structure of the brain, and we've seen this both in animal models and in our patients. We also know that the stimulation of brain circuits produces anatomically precise patterns of activation of brain activity that can be visualized by the fMRI. And we think that these patterns can serve as biomarkers. So we can tell, for example, what is the pattern of activity that's associated with improvements in depression, what is the pattern associated with improvements in memory, in motor function, et cetera. I think that this will greatly facilitate, potentially, the programming of our patients' DBS systems. I've also shown you that focused ultrasound can be used to make therapeutic brain lesions, like the thalamotomy patient I showed you. I've also shown you that we can use it to stimulate the brain in rodents and in humans, and it can also be used to open the blood-brain barrier. And I think this really opens a huge realm of possibilities for delivering of therapeutic agents. The blood-brain barrier keeps everything out that's more than 400 molecular weight, and there are tens of thousands of drugs that now could theoretically be given through the blood-brain barrier once it's open. So I think that it's a very exciting development that we might be able to deliver all these drugs to the brain with opening the blood-brain barrier in this focal manner. Finally, I want to emphasize that the work that we do is multidisciplinary. I happen to be a neurosurgeon, one member of a team, but we work with physicists, we require imaging scientists, engineers, cognitive scientists, and clinicians. And working together, we can achieve great things, and I think that we're going to be able to help many patients. And with that, I want to thank my colleagues. I want to thank you for your attention, and I want to thank you for the great honor of being your 2022 Talairach Lecturer. Thank you very much.
Can you stay for a few minutes of question and answers?
Sure.
Okay. So my understanding is that there is an app on your phone that instead of you going to a microphone, you get to type your questions into it, and it will show up here on this thing that I've got in my hand. And all of you who are live streaming us, you have the access to that same app on your phones. And so I can see all sorts of questions, and it looks like people can up arrow them so that the most important ones will show up here. So I'm looking at a lot of stuff that has nothing to do with this lecture. So wait a second. Where's a question?
I'm not going to answer those.
Yeah, you don't want to. Let's see. About drinking beer safely. I don't think that's the right question for you. Does everybody know how to use this app? This is like, oh, I got a better one. Thank you. Somebody's concerned about your very first patient. They want to know, did they actually lose weight?
In a word, no, did not lose weight. So that patient, we were not able to reproducibly find a place in his hypothalamus that we could suppress his appetite. We were able to find a place in his hypothalamus that produced a sense of uncomfortableness or nausea, and we gave him the option of turning on the nausea whenever he wanted to avoid eating, but he declined to do that. And initially he lost about 30 kilograms, but after a year he was sort of back to where he started. So because of that, we have stopped doing hypothalamic DBS for obesity. We have an N of 1 and we stop there. We don't think that it's the appropriate target. We think it's more of a addiction, regulation problem rather than a hunger problem. So we're shifting our ideas in terms of treating it more like a addiction reward circuit rather than a hunger circuit.
I'm enjoying my app here because it appears that, I'm enjoying the app because it appears that someone actually found his article and copied and pasted the piece out of your journal article with the answer to it in here already.
Okay, good.
So let me go to ones that aren't in there. People are very curious about the focused ultrasound things. They're asking, like, how do you choose the spot that you're going to stimulate or lesion with it? And also they're asking about the time course of the effects. How long do they last?
So the effects are immediate. So as I showed you with this patient, as soon on the table, as soon as we shoot the ultrasound, we see an effect on the tremor. We know from past experience that we've been able to make lesions in various areas of the brain for therapeutic effects, for pain, for epilepsy, for tremor, et cetera. So we know what the targets are. My idea is probably we should stimulate first, so use non-invasive stimulation first as a test, and maybe test across various brain targets, and then choose the one that is the most effective and the safest for that particular patient.
And then how long does it?
Oh, it lasts, so we've operated on 400 patients with ultrasound for tremor, and in 2, we've had to re-operate because the tremor came back. So in 90, over 95% of them, it's long-lasting. We've been doing this since 2012, so that's about 10 years. So it appears to be long-lasting.
So people can hear online. There's questions about the blood-brain barrier disruption is very interesting to people. They're asking about side effects when you do that, and also, is it safe? Can you teach them a little bit more about that?
Yeah, so it is, we use very low energy. Just to give you an example, it takes 5 watts of power to disrupt the blood-brain barrier, and we make these bubbles oscillate, and we focus, about a cubic centimeter of brain at a time. So we can't do a huge volume. We'd have to do multiple treatments. And also, we have the bubbles. We have to inject the bubbles, and then we have to do the ultrasound within 10 seconds. The bubbles only last about 10 seconds. They take 10 seconds to get to the brain, and then they're gone. So you have a short window of time. So far, we've not seen any serious side effects, but we're just opening it in a very small area. I suspect that if we get more aggressive and start doing bigger things, so my colleague Nir Lipsman is treating brain metastases with antibodies by opening the blood-brain barrier, and in particular Herceptin in ladies with breast cancer metastases. And so there it involves opening about a 2-centimeter periphery of the tumor, and so far that looks good so far, in terms of safety. And we can show that there's increased penetration and delivery of the antibodies into the brain, and that it's associated with shrinkage of the tumor. So it looks promising.
All right, I know our time is a little tight. One last question. There's a cool question about the ability to target multiple areas, like as if you were interested, you knew there were a network. So for instance, the person with you might consider the addiction issues, those may be better dealt with as a network. Can you do that?
Yeah, so this idea of multifocal targeting is something that we need to consider. So we can place more than one electrode in a patient. So if you're not certain which target to go to, you can place 2 or 3 or 4 electrodes in the brain on one side or on both sides. And then you can test them or see if there's an interaction between the two. I haven't spoken about this, but there's also this concept of closed loop stimulation where you detect a signal from one area and you use that to then drive the stimulation of another area of the brain. And so that is another very exciting concept in psychiatry and in movement disorders too. So I think that what we really want to do is to know, what are the candidate targets. It would be great if we had a non-invasive way of screening those targets. Say there was an addiction and we wanted to go to accumbens or anterior limb or so on, we could maybe test all of them to see what effects they had on the addiction, and then implant permanent therapies with electrodes at the most promising ones. So that would be great, but doing multiple targets is certainly something we would like to do.
Okay, thanks. So please join me in thanking Dr. Lozano for this awesome lecture.